How does fragmentation impact the dual eligible population, creating barriers? And how can we change it? Welcome to the CarePayments podcast. I'm Fadi Sahar, and with me is Mandy Sahar, the co-author of the VBP blog and DHHQ.
Hey everyone, I'm excited to be here. We just finished up the newsletter on this topic and I'm really ready to dig in. As a reminder, the goal of the Care Payments Pod is to have a quick hitting but informative discussion about healthcare payment models and how they affect MCOs, providers, payers, and care recipients. As an advocacy first group, we want to make sure consumers have the best access to information and quality care as possible. So, in our last podcast, we covered a ton of statistics about the duals population, including that 95% have separate coverage arrangements. Why is coordination particularly challenging for this population?
So, when you think about it, we talked about it in the last podcast, we have multiple payers, a lot of companies involved in processing the payment for the services. Many of the dual eligible population have Medicare as well as Medicaid fee for service. And we're seeing the growth of the Medicare Advantage plans, which are becoming so prevalent with hundreds of them across the country.
So, that's the physical side. What happens beyond physical care?
When you think about the physical health services, they're involving going to the hospital, going to urgent care, going to the emergency room, receiving medication from your primary care physician. When it comes to the other aspects of Medicaid services that make the dual eligible population real, things like the long term services and supports and Medicaid behavioral health. The challenge is when you have multiple payers, everybody is waiting for the pre approved payer to actually process that payment. Medicaid is the payer of last resort. And so as a result, everybody is waiting for the precedent payers to process the care that and approve the care that's needs.
Okay, that makes sense. So, obviously, that addresses the payer's challenges, but what are some of the bigger pain points for providers and caregivers?
So the providers are having to work through this maze of who pays first. And as we hear frequently, in many of these health plans and payers are insurance companies whose first step is to say, I'm not paying for this. Now they deny it, and though as a result, they become less liable for that service or the requirements for the consumer. Let me give you an example: durable medical equipment. Things that could be as simple as a shower chair or a wheelchair, where would be have to be paid for by Medicare first, whichever the Medicare provider is, and they could be multiple. They could be Medicare, they could be Medicare supplemental, before it gets to the Medicaid payer. And so that causes not only delays in approvals, it delays in payments. So as you're dealing with that as a provider, you're actually having to figure out when do you actually deliver the service and who's actually going to pay you for it.
Sounds complicated. So let's talk about the role of integrated care models. How do DSNPs help, and what other models like PACE support dual eligibles?
So think about it. If we can integrate the payment systems so that there is one door, the payers and the consumers have the opportunity to work with a single payer who can then coordinate the care through a single care manager and a single invoicing system. A DSNP is a very good solution to helping integrate that payment environment. But it's also addresses the big issue of knowing what the consumer is receiving and what are their other incidental events that may be going on in their life. So They may have experienced a fall, which is handled by their Medicaid provider, and that's never reported to their physical health provider because it didn't require them to actually go see a doctor or emergency room. So, and you think of the sequencing complexity of Medicare. Medicare takes care of the only the first 100 days within a 12-month period. So depending on when and how much is being used by that consumer, 100 days might be eaten up by days in the hospital, days in a rehab facility. And so, it's like, well, I'm not responsible for this. They've got 96 days that they have spent on Medicare. And so they're still responsible. So we really need to look for ways that make it simpler for the provider and the payer to work in this environment. But at the end of the day, as advocates, we really want it to work for the consumer. The PACE model has come up in a number of states, and we're seeing it pick up steam uh, because it literally uses a single a single insurance platform that covers the consumer, both physical health, emergencies, as well as their long-term services and supports. And so, we're while that model has a very big potential, it does have its uh, negative points, and we are going to spend at least one podcast on this sometime in the near future.
Yeah, I look forward to talking more about those PACE models as we've talked about them. If you and I have talked about them, I feel like there's been, all these good points and then some negatives we've had to dig into. So I'm excited to learn more as we dig into it. So, how does technology play a part in this coordination of care, or how could it help potentially?
Well, think about technology is a very broad subject, right? It's not just the ability to communicate, it's the ability to share data. It's the to share data in a timely manner, to share information about the health and well-being of consumers. But we're also seeing a growing amount of use of remote patient monitoring tools for people with individual with conditions that require such monitoring. And without going on a total tangent, AI is starting to play a very big role in the world of delivering long-term services supports in particular.
I have a feeling there's another podcast about that coming up
I have a feeling you're right.
too.
Uh, it's I want to go back and really think about how valuable the integrated care is for consumers. We really care about the fact that the individuals who are receiving these services are usually old, disabled, and poor. And so they have a hard time on a number of fronts in navigating complex systems. We want to support that. We want to call for more innovative actions. We want better collaboration, better cooperation, and we hope we see it coming soon.
Awesome. So today we've talked about, fragmentation of care and what it looks like currently, what's working, what's not working. Any other key points you'd like to touch on before we finish up?
Well, I think we've got a great start. Let's wrap it up today. Thank you very much for joining us for the Care Payments Pod, and as always, onward.